So let's explore long QT, how it happens and why it matters, because it's so much more than just an overdose on tricyclic antidepressants. I mean, really, who takes those anymore? Hardly anybody seems to be on those anymore. So we'll start with the basics. What is a long QT? 440 milliseconds in men and 460 milliseconds in women, so greater than either of those two. This is one of the reasons why your monitor cares what your patient's gender is, all right? Any QTC over 500 milliseconds is at risk for torsades and or VFib. All right, so you see fatal arrhythmias at anything greater than 500 milliseconds. So how do we know we might be dealing with somebody like that? Usually the EKG is where we find it, but what physical findings should make us suspect it? Fainting is by far the biggest one. And I know anytime we get called out to syncope or near syncope, sometimes we roll our eyes. But especially in the people under 40, which is probably not what you were expecting in a cardiology video, but fainting in people under 40 is by far the most common sign of the long QT. All right, and this is not always anxiety induced, but it can be because this is a response to stress of the heart. Of course, you can see seizures of unexplained origin in young adults and younger people, and then a family history of sudden death is usually what somebody will describe to you. Very rarely does your patient describe a symptom including sudden death. But why? The bottom line is the heart is taking too long to repolarize. That's the whole problem in QTC. If you remember back to your cardiology classes, there was the absolute refractory period and the relative refractory period in the heart. And this is a place where the absolute refractory period is on the back side or on the front side of depolarization. Nothing you do is going to influence the heart. Okay, it's got to be a very strong stimulus. The relative refractory period also takes a very strong stimulus, but there can be other things that can happen that can trigger a fatal arrhythmia. And during the relative refractory period, that could be as little as a PVC. So what do you need to cause a PVC? You need one ischemic myocyte. One angry heart cell is all it takes to trigger a PVC. And if you want to learn more about that, I've got a Mayo Clinic link down here to kind of back up some of the stuff I'm saying. So there are two basic types of long QT, and this is what we need to make sure we remember. One is the inherited, and this is split into three subcategories, Ramona-Ward syndrome and then Yervil-Lang-Nielsen syndrome. You can read more about these conditions, but they're pretty awesome. They've been tied to genetics. The research, rather, is awesome. They've been tied to genetics. And SIDS is also being investigated post-mortem by its genetic markers, and they're finding some pretty decent percentages of sudden infant death syndrome victims had a predisposition for long QT. So this may help us crack that mystery. There is also acquired long QT syndrome, and you can see drugs right here, antipsychotics, some antibiotics, diuretics, cholesterol medications, antihistamines, some diabetes medicine, and there is a greater list of specific drugs. If you go to this link to the right, there's a PDF where you can get it's a pretty comprehensive list. It's pretty good stuff to read and stay up on. So where do we look for long QT? Immediate or first degree relatives with a known long QTC. It's a dead giveaway. Be looking for long QT, especially when your patient is a victim of syncope or seizures that are unexplained. Persons that are under 40 with unexplained dizziness or fainting, that's another red flag. Hey, this could be long QT. People with electrolyte imbalances or reasons to have electrolyte imbalances is another one. Eating disorders, such as anorexia or bulimia, they lead to electrolyte disturbances, which can cause long QTC. And then some thyroid disorders and the therapies for them. So it wouldn't be shade tree cardiology if we didn't throw up some electrocardiography up here. And here's just a quick reminder of some of the standard morphology of a long QT interval. All right, so get out there and practice.